Good evening, beautiful people, and welcome to this week's Healthier You episode here on Radio Maria 91.3 FM, the voice of truth. We're very happy that you all could join us today for another knowledge-packed show. I am Stephanie, and with me in the studio is
Ekene, and I trust we all are doing great and we're all having a beautiful week. And we hope you have a wonderful time with us over the next 1 hour.
Okay, yeah, today is another power-packed show, and we're going to delve right into it. We've often talked about malaria. You know, Ekene, malaria every day. People walk into the hospitals. If there's a headache, it's malaria. If there's a body pain, it's malaria, you know.
Malaria
so it's just what we know in this part of the country. Everybody knows his or her malaria symptoms. Like, and how do you know you're sick? You know, so we've often talked about malaria and how much of a burden it is to us in the world, and even more in sub-Saharan Africa. Of course, we were talking about sub-Saharan Africa with us here. However, today we'll be looking at a particular subset that is of utmost importance if we are to win the fight against malaria. Today we'll be talking about malaria in pregnancy. We want to be specific because of the presence of malaria in pregnancy and what it actually does or causes. So in the year 2020, there were an estimated 33.8 million pregnancies in 33 moderate and high transmission countries that are parts of the World Health Organization African region. Out of this number, 11.6 million, which is 34%, were exposed to malaria infection during the period of pregnancy. By World Health Organization sub-region, West Africa had the highest occurrence of exposure to malaria during pregnancy, taking about 39.8%. Central Africa came in next with 39.4%, while prevalence was 22% in East and Southern Africa. Wow, Ekene, these numbers.
I mean, hearing these numbers, you can see why it's very important that we bring this topic your way. When we talk about 39.8% in West Africa, I mean, we all know that Nigeria will take it like
with 200 million people.
I mean, a large chunk of that number.
Yeah, so
it's really important that we talk about this. Today we are joined in the studio by a very special guest, a friend of the house. He's no other person than Dr. Akpiroroh Ikechukwu. He's a resident doctor in Aflad General Hospital, Riyadh, Saudi Arabia. And he's also a public health advocate. And currently he's on vacation. And he was kind enough.
I'm telling you, I'm not lucky to have him in our midst. His experience from Saudi Arabia and bringing it down here. Of course, he was even here before he left. So with his vast knowledge, he'll be able to actually tell us what is that and what is this, you know. So
we're very happy to have you today with us, Dr. Dim. And just to avoid any confusions, we'll be referring to him as Dr. Dim.
Yeah,
so we don't have to guess.
That's what we are very comfortable with.
So, Dr. Dim, please, can we meet you?
Okay, I'm Dr. Ikechukwu, and just like you mentioned earlier, a resident doctor in Aflaj General Hospital, Riyadh, Saudi Arabia, and presently on vacation. Thank you.
Okay, thank you very much for taking out time out of your relaxation. I'm sure it's very much needed, but you decided to be here with us, and it's all for the job, and we're very appreciative of that. Right now, we'll be going on a short break, and when we come back after the break, Dr. Dim will help us to do justice to the topic of the day, which is malaria in pregnancy. So this is still Healthier You on Radio Maria 91.3 FM, the voice of truth. Don't go nowhere.
Welcome back to Healthier You, right here on Radio Maria 91.3 FM, the voice of truth. Healthier You is our health talk show program that airs every Tuesday by 4 p.m. here on Radio Maria. If you're just joining us today, we shall be talking about malaria in pregnancy with our guest, Dr. Akpiroroh Ikechukwu, who is a resident doctor
with the Aflad General Hospital, Riyadh, Saudi Arabia, and he's also a public health advocate, and he has been kind enough to join us today. Dr. Dim, are you ready for us?
I am.
Okay, shall we then?
Okay, please, before we continue with our program, we want to tell you our phone lines, which will be opening up in 30 minutes' time when we have done a little talking. And the phone lines still remain 081 084 475 18 081 084 475 18. So you can send in your SMS or WhatsApp messages and also call into the program for your questions, observations, and contributions.
So, Dr. Dean, during the introductory part of the show, when Stephanie read out the numbers about the malaria in pregnancy in African region, because our particular area of interest will be Africa because we're here, and that was about 11.6 million, which is 34% of the total pregnancies recorded in Africa. And given this data and the numbers, would you say that malaria in pregnancy is a public health challenge?
Of course, malaria in pregnancy is a public health challenge, and as a matter of fact, in Nigeria, about 40% of public health expenditure is centered on treatment of malaria. And if you go to the hospitals, you see that about 30 to 50% of admissions, and within those admissions, we have pregnant women who are also admitted. 30 to 50% border on malaria, and about 60% of clinic visits, including pregnant women during the antenatal period, border on malaria. And you see that so much money is being spent on the treatment of malaria. And on a conservative estimate, it has been stated that about 132 billion naira is spent on a yearly basis.
That is a whole lot, 132.
Yes. Wow. So it's a very big public health challenge.
And I think this is one of the things where we cannot be overemphasized, the importance of antenatal clinics. Because, if you find people, even within the supposedly educated ones, that don't really take these things seriously.
I even think that this era of internet surfing and media, people think they have access to all the information. So, okay, it's what I want to do, and I'm okay with that. I can even do my self-help and all that. And people don't know that on sites, when you assess the person on site, there are a lot of things. It's different from when you put a call across or ask questions online.
And when we talk about malaria, we know we have areas of low and areas of low and unstable transmission, and we have areas of high and stable transmission. So malaria in pregnancy, how does it define in those areas? And please, could you just help us define what it means by areas of low and unstable transmission, and then areas of high and stable transmission? And then we talk about malaria in pregnancy. Yeah. Talk about malaria in pregnancies in these areas.
Okay, for the areas of low or unstable transmission, it actually borders on endemicity. There are places where malaria is highly endemic. For example, Nigeria is a holo-endemic region. Okay.
Please, sorry, let
me in the sense
that okay.
Now,
let's just break it down for people. When we say endemic, what do we actually mean?
Yes, and endemicity is actually how you describe the presence or prevalence of a particular disease, just like malaria, in a particular area. Okay. Now, for places where you have low or unstable transmission, now for places like in the temperate regions, okay, like Europe and even North America, you see that the rate of infection with Plasmodium, of course, which causes malaria, is very, very low. So sometimes there may be, during seasonal regions, during summer, of course, malaria parasite is usually transmitted during periods of high humidity, okay, periods of high temperature, okay, and you see that those places might see some infections with the Plasmodium
and this
parasite.
People take it very serious. So when they catch somebody with malaria, it's a big issue.
Yes, of course.
Very big issue.
So in such low endemic regions, low places of transmission, you have decreased infection. Now, what this means is that with such decreased infection, the immunity of the people within that area tends to be low.
Okay.
Of course, in pregnant women, pregnancy already reduces the immune system, okay, because of the hormonal changes. Yes, in the woman's body. So you see that with infection with malaria parasite, the immunity also tends to be reduced. Now, in those areas of low transmission, you see that with decreased immunity, what it means is that if the person is infected with the Plasmodium parasite, the severity of the malaria tends to be high because the person has not developed enough immunity, produced antibodies, things that fight against infection, in this case malaria parasite, the person will not have produced enough antibodies to fight against this malaria. And in those areas of low transmission, it affects all women, be it your first pregnancy, second pregnancy, third pregnancy. Okay, it affects them at the same rate. So such places need increased screening and treatment. However, when you come down to Nigeria, on sub-Saharan Africa, which is actually our concern in this case, you find out that we are in high or stable transmission. High transmission in the sense that all year round, people get infected with malaria.
It's not an infection for us again. In this case, we just tell you that it's just part of ordinary malaria. You know, so in this part of Nigeria, and Nigeria like as a whole, we're taking it like, okay, it's part of us. We carry malaria now every day.
Yes. So you find out that, of course, during the rainy seasons, when you have increased humidity,
yes,
and of course with we are in the tropics, so we always have high temperatures all year round. Okay.
And then waters around, I guess.
Around where mosquitoes can breed. So you see that there may be a little spike during the rainy seasons. Okay. And these are areas of high transmission, which Nigeria is one of them. Okay. Now, in areas of high transmission, you see that infection with malaria parasites tends to be high, just like we mentioned. And with repeated infection, the body tends to develop immunity. Okay. Immunity is that, you know, a body preparing for subsequent attacks. Yes. Okay. So with immunity, what it means is that pregnant women, after the first pregnancy, tend to develop immunity. So the severity of malaria in subsequent pregnancies tend to reduce. Okay. So in first pregnancies, you have to be very careful about that, because newly married couples, many a times, of course, they may plan for pregnancies, but sometimes they may not plan for pregnancies. So you realize that before the pregnant woman, we know that she is already pregnant.
She could be far gone.
She could be up to 2 months, or even the 3rd month, or okay, within the first trimester. And this is a very delicate period in terms of transmission of malaria. So what this means is that with increased antibodies, okay, and then the woman in her second and third pregnancy, just like we mentioned earlier on, the severity of malaria tends to reduce. However, you find out that with government interventions and, you know, malaria control measures, insecticide treatment nets, and all the control measures, you see that in certain regions, especially in urban regions, the incidence of malaria tends to reduce. And with such reduction, immunity garnered over the years against malaria might wane. So such persons, even though they may not have similar level of immunity like those in the low transmission, but they need to pay more attention to the possibility of being infected with Plasmodium parasites.
And we can see some positive sides to being in Nigeria, in this part of the world, considering the fact that we have better immunity to this. And also during the course of the research for the show, we had seen that seemingly mosquitoes, they have an affinity for pregnant women. And I want you to verify if this is true or false.
Let's not put people on the edge now.
I mean, but these are things that are important to discuss.
Yes.
So is it true that they have some form of affinity for pregnant women? And if yes, what's the reason for that?
Well, you might say they have affinity for pregnant women because, of course, there are some changes in pregnancy which might make them to be predisposed to mosquito bites. For example, pregnant women, especially in their second and third trimesters, in their from 4 months to 6 months.
Everywhere is on fire.
To 6 months. Now, first trimester means the first 3 months. Yes. Second trimester, second 3 months. Third trimester, third 3 months. Yes. So you see that they tend to exhale more, about 20% more than the non-pregnant women. And studies have shown that female Anopheles mosquito, which is actually the culprit, that transmits malaria parasite from person to person, tends to have affinity for moisture and exhaled carbon dioxide. So, of course, since pregnant women exhale more than about 20% more than those that are not pregnant, it means that they will attract more mosquitoes to themselves.
Okay.
That is number one. Number two is that pregnant women also, it has been shown that their abdomen, their tummy, okay, the temperature of their tummy tends to be about 0.7 degrees higher than that of the non-pregnant women. Of course, you know, to the common man, we will use tummy, but of course, the baby grows in the uterus, which distends the abdomen with increased blood supply to the uterus, to everything around the abdomen. So if a non-pregnant woman has a temperature of 36.4 degrees, for instance, it means that the pregnant woman, the abdomen, will be about 37.1. And just like we mentioned earlier on, the female Anopheles mosquito tend to prefer humid and warm
parasites,
areas.
Many parasites, they just love that one place where they can incubate and, you know.
So with that, you can actually say they have affinity for pregnant women. And another point is, which may not necessarily be affinity, is that with distension of the abdomen, the uterus, which is the womb that harbors the developing baby, occasionally rests on the bladder, compressing it. What it means is that pregnant women tend to urinate more often than the non-pregnant women. So for places where the restroom is not situated in the house, they tend to go outside often, and then they'll be predisposed to mosquito bites.
Okay.
Wow. That's a lot of information today.
Very, you know.
Anyways, we'll be going on a short break now. When we come back, we'll further dive into the topic of the day, which is malaria and pregnancy. And let's not forget, within the next 15 minutes, the phone lines will be opened. And the phone number again is 081 084 47518. I'll take that again. 081 084 47518. Please stay tuned. Don't touch that dial.
Welcome back to Healthier You on Radio Maria 91.3 FM, which airs every Tuesday on your radio station, Radio Maria 91.3, the voice of truth. If you're just joining us, we've been talking about malaria in pregnancy with Dr. Diman Nurum Ikechukwu, who is a
resident doctor
in the General Hospital at Riyadh. He's on vacation right now, and he has found out time to come and discuss this very pertinent topic with us. And it's been a very interesting one. He started with telling us how malaria thrives in humid regions and this part of our world, and why it is prevalent here, and how we've developed immunity in this part of the world. Okay, he has also said it's an endemic in this part, and we also delved right into the pregnant woman affinity for mosquitoes, you know. And then he talked about carbon dioxide, that pregnant women exhale more than others, and so it's able to attract the Anopheles mosquito and all that. So he has been doing a good job on that, and we'll continue right now.
So Dr. Dean, I mean, we've talked about how malaria in pregnancy is a public health challenge, but to give us better understanding of what we're dealing with, could you tell us some of the effects of malaria in pregnancy on the mother, on the women?
Okay, thank you so much. The effect of malaria on the woman, of course, when you look at the transmission cycle of malaria parasite, okay, you see that if Anopheles mosquito, female Anopheles bites a woman, injects the stage of the parasite, which is called the sporozoites. They go to the liver where they multiply, then send out more parasites into the bloodstream. They now infect the red blood cells. They multiply further and then come out of the red blood cells. I think
it's at this point of the infection of the red blood cells that you have the more pronounced.
In fact, at the infection of the red blood cells and the release of merozoites. Merozoites are a stage of the Plasmodium parasite. Of course, in our region, we have more of Plasmodium falciparum. There are 4 types, okay? But here in Nigeria, we have more of Plasmodium falciparum. So you see that the effect on the woman stems from this process, okay? Because with the release of the merozoites, breakdown of the red blood cells, the body tends to fight against this Plasmodium. You know, there will be temperature, what they call cytokines, interleukins, tumor necrosis factor. All those things are released into the body to help to fight against infection. The woman tends to have fever, will have headache. Already, because of the hormone imbalance and disturbance, which you mentioned earlier in pregnant women, the appetite may reduce. Now, with malaria infection in this pregnant woman, her appetite may further reduce.
Wow.
And she's not eating only for herself, she's eating for herself and the developing baby.
But doc, you know, when we talk about this, they say some pregnant women eat a lot.
Yes, that's why I say the hormone imbalance. Now, no two pregnancies are the same, even in the same woman. Okay, a woman might have these symptoms in her first pregnancy. She may not have symptoms in her second pregnancy. But generally, it has been shown that, of course, you see that appetite tends to fluctuate. You may have increased appetite or reduced appetite. So for a woman who, for example, has reduced appetite, coupled with malaria infection, which further reduces the appetite.
Because even when you're not pregnant and you have malaria, to even eat is a problem.
Exactly.
You know?
So you have headache, you have fever, and all the signs of infection. You have joint pains, generalized body weakness, okay? And you realize that with the release of these merozoites from the blood cells, they break down these red blood cells. So if a woman who has not been eating very well, who has not been attending antenatal visit, who has not been taking her supplements, the ferrous sulfate and the folic acid,
and the vitamin B complex.
Exactly. You realize that already her blood level will be reduced.
And of course, doc, I'm sure that's
in malaria,
anemic in malaria.
Exactly. So you see that malaria will further worsen the reduce. That is what they call double wahala.
Imagine you are carrying another person inside of you, and you can't even nourish your own self, and then you're talking of your blood level dropping. Even when you are alone, your blood level drops. I know what it entails, not to talk of
when there's a child involved.
A child growing.
Exactly.
You know?
So you realize that even with the malaria parasite, the folic acid in the body tends to be reduced. So for a woman, especially the first trimester, who is not taking folic acid and now has malaria, she will not be predisposed to the baby having neural tube defects. Now, neural tube is what forms the brain and the spinal cord.
Okay.
Okay. So with further reduction in the folic acid that is present in the body for the development of the baby's brain and spinal cord, it might have deleterious effect on the baby. But for the mother, anemia is one of the common effects of malaria in pregnancy, especially in the rural areas.
Yeah. Yes. I mean, that would make sense because of the lack of quality health care and everything.
Not just the lack of quality health care,
ignorance,
you know,
too,
and
yes.
it's not just that, the feeding pattern and all that, you know. So a lot of things come into play when we're talking about all this, and people are not aware. They just feel that, okay, it's normal, malaria is abeg, just leave it for us like that, you know. But there are a lot of contingencies in place, things that we should actually take note of, and that's why this program is coming to enlighten people on what they should actually know and what they should do.
Now, a very bad or extreme aspect of it is that, just like we mentioned, a woman who is pregnant may actually have reduced blood level because of possibly inadequate nutrition and supplement intake, okay, and she now has malaria. If she, per adventure, develops postpartum hemorrhage, that's bleeding after childbirth, she's more likely to die from that bleeding than a woman who has optimum blood level and who does not have malaria in pregnancy. So you see that prompt diagnosis and treatment of malaria in pregnant women is actually of utmost importance to prevent such cases.
And again, I think we have to also re-emphasize on the importance of antenatal care.
Yes,
something
seriously,
that can be
because you can't be at home and assume that, okay, it's just the normal pregnancy symptoms I'm having, and meanwhile what you're actually having is malaria, which needs to be treated. And of course, doc, treating malaria is in pregnancies, a different thing altogether than the normal walk into the shop and give me anti-malaria. I hope people know that, because it's one thing that I know that affects people a lot.
Yes. So now we're moving away from the mother. What's the effect on the fetus?
Now, there is this tendency for Plasmodium parasite, which is the parasite that, the malaria parasite, it has a predilation, an affinity for the placenta. So what it does is that, the placenta has a very huge blood supply. It's very soft, it's very nutritious, and Plasmodium likes good things.
Yeah, yes. Nutrition.
I like better thing.
I like better thing.
It will go there and, relax and, block the whole place. So what it does is that with such, let me use the late term, blockage, it tends to reduce nutrients from getting to the baby. So if nutrients, there's a reduction in the nutrients that get to the baby, of course the baby will not grow optimally. So you have intrauterine growth restriction, in the sense that the baby that is in the womb will be restricted, will not grow to its full potential.
So could this be like the cause of some deformations in?
More of just growth restriction, not malformation.
Okay.
So
now, for the folic acid we mentioned, you might have malformation. Where you have the lower back of the baby, what we call spina bifida. It might not be visible, spina bifida occulta. It might be meningum myelacea, where you have the spinal cord protruding from it,
or just
medical
term is just the
now just the spinal cord. Now, so what this means is that this malaria parasite with intrauterine growth restriction, if you follow the sequence, you see that this child may be delivered with a low birth weight. The growth is restricted in the womb. What it means that the growth at the end of the gestation during the pregnancy period will be reduced. You have a low birth weight. Now, malaria in pregnancy, we can also call it placenta malaria, where you have parasites in the placenta, can lead to stillbirth.
Wow.
Yes, it's good people understand it so that people will not say village people.
Okay, because this stillbirth, they'll be like, okay, they've called them from the village and all that.
So you see that it can lead to stillbirth. It can also lead to preterm delivery, a baby that is delivered before the 9th month. Okay, and now you have different stages of preterm, and then you can see that in children, when they are giving birth, especially it's quite rare, but it still occurs, especially in rural areas. You can have congenital malaria, where a baby is delivered and baby has malaria.
Wow.
Now,
at the point of delivery.
At the point of delivery. Now, what this means is that, just like we've mentioned earlier on, parasites invade red blood cells and destroy them. So when they destroy these red blood cells, you see that the liver, tries to degrade these red blood cells. Okay, you see that this baby might come out with jaundice at the day of birth. The spleen is the organ that removes infected red blood cells from the bloodstream. Spleen might be enlarged, and a whole lot of other problems that the newborn baby might have.
From Zuba. Well, I think he was actually talking about
bleeding in pregnancy.
Yes.
That's what he was trying to put across, I think.
Well, it may not really be... I remember you made mention of sticking to the topic, which is malaria in pregnancy. However, malaria studies have not really shown malaria to cause bleeding. Bleeding in pregnancy is actually called antepartum hemorrhage. Yes, bleeding while the woman is still pregnant before delivery.
Thank you very much, John. I think John was trying to tell us that there should be more focus on the prevention than in treatment.
Yes. The government has spent a lot on treatment and actually
exactly. Earlier on we made mention of treatment of malaria in pregnancy. Malaria generally in Nigeria, costing about 132 billion naira. That's a conservative estimate, okay? I think his emphasis is on prevention. We have about 4 levels of prevention. We have primordial, primary, secondary, and tertiary prevention. Now, for the dirty water, he mentioned dirty water being around the environment, which I believe, Stephanie, you mentioned is a breeding site.
Right, yes.
If you know the life cycle of malaria parasites,
yes, of course.
Female anopheles, they lay their eggs in still bodies of water, okay, where the young hatch from. Okay, once you eliminate that environment for them to breed, exactly, they will not breed. So having dirty water, removing dirty water around the environment or stagnant water falls within primary prevention. Okay. Now, for the government, you know, coming into help in preventing malaria parasite, government can actually play a role in primordial and primary. Primordial involves policies.
Yes.
Government can make a policy. Let's say from 2024, nobody should build a house without putting mosquito nets.
Okay.
Anybody that builds a house and there is a window in the house and there is no mosquito net will be prosecuted. That's a policy.
And we also see that gutters should not be opened around the
Exactly.
residential areas.
There could also be policies about not having open drains, open channels, and all that. And it's still part of the policies because we will still mention it in the prevention and then treatment of malaria. You see that studies have shown that women who are educated up to secondary school level tend to have a lower incidence of malaria in pregnancy because they accept, you know, they are more likely to accept all the preventive methods that will come to them. So government can actually make a policy that all girl children must be educated up to secondary school level.
Okay.
So primordial deals with policies, government policies, campaigns, okay? So for the primary dirty water, you can have campaigns and then clean up, sanitation, making sure there is no body of water around that place.
We have a call now, so doctor, please hold your thought. Good evening and welcome to How Dare You. What's your name and where are you calling from? Hello? Okay, I've lost that call. Sorry, doctor, please could you continue?
Okay, yes, for the primary prevention, we can actually have, in addition to having, making sure there is no stagnant body of water around our environment, okay, there should also be increased use of insecticide-treated mosquito nets, and then, what do you call it, residual spray. Residual spray is this insecticide that people normally spray.
Those things, are they not harmful, you know?
Now, I think somebody asked me a question some time ago about, you know, that you have insecticide, those ones that smell fine, those ones that don't smell fine. Can they spray the ones that smell fine and stay in the room? I used a little analogy. For example, vitamin C, for instance, both the white and the colored, both contain 100 milligrams of ascorbic acid, okay? So those ones that smell fine in terms of the insecticide and the ones that don't smell fine, they contain similar things. They are not good for the body, for you to stay inside. So if, depending on the number of apartments you stay in, you can spray the insecticide in the living room, stay in the room, yes, and then when you open your windows, of course, there should be mosquito nets in those windows so that they will go out, the insecticide will go out, of course. By then the mosquitoes would have died, and then you go to the living room and spray the bedroom, okay? These are all parts of primary.
Those coils, those ones they burn.
These are still readily available.
Yes, I think
they have mostly been discontinued.
Yes.
Yeah. So that's primary prevention. Then for the secondary prevention is prompt diagnosis and treatment of pregnant women that have malaria. Okay. Now, if you diagnose a pregnant woman that has malaria promptly and treat her, you have prevented her from transmitting the malaria to another pregnant woman. Because if a female Anopheles mosquito has a blood meal, the mosquito can escape and bite another pregnant woman. Yes. So once you diagnose the pregnant woman and then treat her promptly, you have prevented infection of another pregnant woman. That's why during the second trimester, they call it quickening, 16 to 18 weeks, depending on the woman's pregnancy. Is it the first pregnancy? That's quickening is the time the woman feels the first kick of the baby, okay? They are giving intermittent preventive therapy for malaria, sulfadozine, pyrimethamine. There are several brands, okay? Without testing. So that helps in treating the pregnant women. So it serves as a treatment in case they have malaria for them and their babies. And it also serves as a prevention because it will prevent them from transmitting the malaria through the mosquitoes to another person. Then the tertiary prevention is, of course, treating complications that come with malaria. You know, when a pregnant woman has malaria, has anemia, just like we mentioned, or low blood level, and you give her blood transfusion, for instance, to build up her immunity, you would have treated the complications that come with malaria. At the same time, you would have prevented her from having severe malaria in case she comes down with malaria.
Okay, Doc, you mentioned sulfatoxins for pregnancy, malaria and pregnancy malaria and pregnancy treatment. That's the safest, because we just want to reiterate to people out there that that you're a pregnant woman and you feel that you're having some headaches, your body joints, and you feel it's always your usual symptoms. That okay, I mean, malaria is different. You're not just allowed to walk in to any pharmacy or anything. You need to properly be diagnosed and properly be treated by your physician who is taking care of you.
Exactly.
I think it's very important to make sure that it's your physician. You don't just walk in and buy.
Exactly. Because the WHO standard, sorry, please. The WHO standard is that you should test and treat.
Yes.
You don't just treat malaria. Now, the goal of testing and treating is because we do not expose we will not have to expose people who do not have malaria to anti-malarials. You know, the reckless use of anti-malarials will lead to resistance. That was what happened to chloroquine.
Drug, yes.
So now chloroquine, when you take it, the parasite will just be licking it like ice cream.
But this is not what we always used to. And I think many Nigerians, the malaria is just so used to our okay, just go and get me this one, go and get me that one, and then they've taken it again. Okay.
And there's also the fear of teratogenicity too. Not just taking like taking something that will affect your child and stuff like that.
Now there is this drug mefloquine is used to treat malaria, at the same time prevent can also be taken as a preventive medication, because it actually gets what they call hypnozoids, malaria parasites that hibernate. Yes. They just relax in the liver, waiting for when they will come out. Okay, but mefloquine tends to disrupt G6P, the glucose 6-phosphate dehydrogenase. Now, some babies may be born with this deficiency. Okay, and if such women take mefloquine, it's not part of our malaria treatment protocol in Nigeria, but it's just to buttress the point that you just made.
Yes,
those children might be exposed to the tendency to bleed. Okay, and of course it will not be good for the baby. For the diagnosis of malaria, the gold standard is microscopy. You take a blood sample, you put it on the slide, look at it under the microscope, and you look at it. But then there are newer systems, the rapid diagnostic tests. Now, specificity of microscopy, looking at under the microscope, is 100%. Yes. Once you see the parasite,
gives you the level
you will see it there. But then there is something that is worthy of note, that women in their first pregnancies tend to have more symptoms of malaria. So when you check their peripheral blood film, that's the blood from their veins, from the arm, for instance, there is a likelihood that you will see the malaria parasite. But women who are in their third, fourth pregnancies, when you look at the blood in their bloodstream, you may not see the malaria parasite, but it might be present in the placenta. Yeah. Okay? Now, that's where the rapid diagnostics will come into play. Yes. The rapid diagnostics actually targets an antigen, histidine-rich protein 2. Okay? And then the lactose dehydrogenase from the parasite. Okay? As the parasite is in the body. Okay? Now, this rapid diagnostic test will get women who have malaria, but in their peripheral blood film is not there. So you see that even though, yes, women in their third, fourth, fifth pregnancies may not exhibit the symptoms of malaria, but they are more at risk to have children who have effects of malaria in pregnancy.
You know, you mentioned this glucose dehydrogenase, 6P dehydrogenase and all that. Okay, you know, these things, we keep talking about these things. And when we just keep wrapping everything back to nutrition. Okay, because your nutritive value determines you. You know, you are what you eat, and we'll keep talking about this. And when you eat right, you will get the right nutrients. Okay, that you're a pregnant woman doesn't mean that everything you see that you eat, even when it's not balanced. Okay, so you need to actually work towards balancing your diet so that you can.
So we're going on a short break now, and when we come back, we'll wrap up on our program for the day. Please stay tuned. So, truth, if you're just joining us, we've been talking about malaria in pregnancy with Dr. Akpiroroh Ikechukwu. He is a resident doctor who's practicing in Saudi Arabia, and he's currently on vacation, but decided to take out time to come and be with us today. Doctor, so quickly, if you see our time is already fast spent, so let's just talk about the treatment of malaria in pregnancy. What are the gold standards or the recommended procedures for treatment?
Okay, thank you so much. For treatment of malaria in pregnancy, just like Stephanie rightly mentioned, it's not something that you just walk into the pharmacy, please give me anti-malaria, I have headache, I have fever. As a matter of fact, there are 1,001 things that can cause fever and headache in anybody.
It's very important,
more especially in pregnancy men. So you realize that, as we mentioned, there are 3 phases in pregnancy: first trimester, second trimester, and third trimester. Okay, it has been shown that the best treatment for malaria in the first trimester is quinine. Okay, not chloroquine, quinine, which is usually, you can, depending on how you want to administer it, but it has been shown that quinine causes reduction in blood glucose in the body. So for the pregnant woman who may not even be eating very well, to take quinine, it may not be readily advised, except maybe the patient is admitted and the quinine is now put in an IV fluid that has glucose, and the woman is given the quinine. Now, that's the first line. Second line, you can, for the first trimester, you can actually use the common artemether lumefantrine. The ACT will have readily available. It's quite safe. It has been, previously, there were some reservations, some gray areas. Does it cause, is it teratogenic, just like Ekene mentioned? Does it cause malformations and all that? But several studies have shown that there are no such malformations. So it can actually be used in the treatment of malaria in the first trimester.
By your physician.
By the physician. So, of course, there are so many things that can cause fever. Somebody can even have cancer of the brain and have headache without knowing. And we'll be treating malaria, tumor growing in the brain. And we'll be busy taking artemether lumefantrine. This malaria This malaria no
okay, make I go take injection.
Make I go take injection.
You know.
So you see that. So for the second trimester, just like we mentioned earlier on, at 16 to 18 weeks, which is the time the baby kicks for the first time, the woman is given sulfadosine pyrimethamine. Okay. During that same period, ACTs can also be given. Okay. That's why, just like you mentioned, it's good to see your physician so that he can discuss with you for the pregnant woman and decide on the best management plan. And then for the third trimester, you see that you can also use sulfadosine pyrimethamine, and you can also use ACTs. So what this means is that in the 3 trimesters, you can actually use ACTs within that period. But it has to be confirmed that you have malaria parasite before you take it.
Okay, so finally, on a quick note, recently there's been the talk about the advent of malaria parasite vaccine for pregnant women with malaria. So do you think that the advent of the pregnancy malaria vaccine would be a crucial breakthrough in the fight against malaria in pregnancy?
Yes, of course. Well, presently there is no vaccine for malaria in pregnancy, but there is vaccine for malaria in children less than 5 years.
Okay.
In fact, they have pilot studies in about 3 countries: Malawi, Ghana, and Kenya. Okay, and so far so good. Since 2019, they have seen that in many of the volunteers, it has helped to reduce the incidence of not just malaria, but severe malaria. But of course, since it's a recombinant vaccine, okay, there are reservations for women in pregnancy. You know, for women in pregnancy, for women that are pregnant, okay, you realize that extra care is taken before any medication or any vaccine is approved because of the potentials of the vaccine affecting the baby. But I think the vaccine is more accurate. You know, RSA/S, RTS/S, exactly. So you realize that for it to be given to pregnant women, of course, it has to pass through a whole lot of tests to make sure that it doesn't negatively affect both the woman and the baby. So, and so far, even for the children, there is this Vaccine Alliance, Gavi. They have promised to pay about 80% of the cost for this malaria vaccine, which Nigeria, fortunately, has subscribed to. Wow. And then the government will pay 20%. So in this case, you know, at least the effect in children can give us an idea of what the effect in pregnant women will be. So when it's finally approved for pregnant women, it will be a very good breakthrough, because all these things we've mentioned about prevention, of course, we will still maintain all those preventive measures. But if the woman is now beaten by a female anopheles and the plasmodium is introduced into the bloodstream, the possibility of the woman having malaria will be reduced. Yes. Even if the person has malaria, just like COVID, it will be very mild. Yeah. Okay. It will not be severe.
Oh, it's been a wonderful Tuesday evening discussing about malaria and pregnancy. Dr. Dim has done a whole lot of job on this malaria and pregnancy. I'll just run through what we've been talking about. We've been talking about pregnant women. Take proper care of yourself, because yes, we have had a lot of points. We have that the life cycle of the plasmodium, when it gets to the liver, it can cause jaundice for the child if it remains there and not well treated. We have the fact that when it goes to the merozoite stage, the red blood cells, it can also cause anemia both for the mother, who is also, you know, affected and all that. And you know, when a mother is anemic, it becomes an issue. Okay, so there are supplements given when you are pregnant. You have the folic acid, which is necessary in pregnancy for child formation and all that. So it's not something you just shelve. It smells, you know, pregnant woman has it smells and all that. Okay, but I know there are other packages that you have it inculcated in them and all that. So please take your supplements, because they will help in the child development. You see a lot of congenital issues. You see children with a lot of malformations. He talked about the spinal issues that comes along with it. Okay, so these are complications that come from pregnancy in malaria. And what have we been saying? Your nutrition, seeing your physician when necessary is very important. And of course, government policies, enlightenment, campaigns, prevention stages, use treated malaria nets. Make sure your environment, you don't have stagnant waters, and then of course clean it up properly. Use insecticides when you are not in the room. Okay, so this is what we've actually gone through today. And our callers, we have a caller who also called in and gave a lot of contribution into the program, and so we are grateful to our callers and our listeners who also have found out time to always be with us. And to Dr. Dim, can we get your final word on this? And just
okay, I will advise our listeners, especially the pregnant women, to know that the burden of malaria is quite is real. Okay, even though, of course, we may not see, especially in the urban areas, we may not see women who have died from malaria, but in the rural areas, a whole lot of women have complications that stem from malaria in pregnancy. So I will advise them to take care of their health, their nutrition. They are to be very serious with their antenatal. And if they feel anything that looks like symptoms of malaria, they should not fail to go to their doctor and get a consultation. Of course, doctor will take a history, possibly perform a physical examination, request for some tests, which we call investigations, and then give the appropriate treatment so that both mother and baby will come out of pregnancy very well.
Thank you so much, Dr. Dim. And I'm going to say this quote by Bill Gates, and we know he's a very passionate person about malaria. And he says there are more people dying from malaria than any specific cancer. So let's all endeavor to always contribute our quota to achieving a healthier living. Healthier You broadcasts every Tuesday by 4 p.m. right here on Radio Maria 91.3 FM. We hope to have you all tune in next week. And please do stay tuned to Radio Maria 91.3 FM. Child Protection with Mary Angela comes up next. From Stephanie and I, we say, do have a good evening.
And thanks for joining in.